세 번째 연자는 경희대학교 한의과대학 이범준 교수입니다. 호흡기 내과를 담당하시는데요. 참고로 호흡기 내과는 경증 환자의 제제약을 사용하는 것에 대한 지침을 발표하기도 했었습니다. 이번 진료 권고안을 가지고 진료한 모든 한의師들이 내용을 지속 검토하고 조언하는 자문단에서 활동하셨습니다. 발표의 제목은 Management of Mild COVID-19 Patient with Telemedicine of Korean Traditional Medicine, a Retrospective Observational Case Series입니다.
Hello, my name is Lee Beom and I am a professor affiliated with Kyunghee University. My talk will be on the results regarding how we used herbal medicine through telemedicine for COVID-19 and the results that we published as a retrospective observational case series. Regarding how we would analyze the data and synthesize it, we were not well prepared regarding how the data was collected in telemedicine. However, in the next pandemic, I think we will be able to be more prepared regarding how to collect data more systematically in our next endeavors. This study was conducted as a retrospective observational case series, and my talk will be regarding this. As of March 2020, the first pandemic mass spread occurred in Korea in the Daegu region, and the Korea Centers for Disease Control and Prevention operated a system in Daegu, which was very effective. One of the things that the Korea Centers for Disease Control and Prevention did very well was that they tiered and classified patients and also provided treatment accordingly to these classifications. This is considered to be well controlled and managed by the Korean CDC, and the severity class were determined by public health center doctors who interviewed patients over the phone. And the severity class was defined as follows. Out of suspected cases, the cases that were confirmed to be asymptomatic or mild were segregated to self-isolation in their homes or at community treatment centers. And this was one of the reasons why the Daegu hospital community and medical care did not self-destruct from overload. However, regarding asymptomatic and mild patients, direct management guidelines or treatment was not provided. And so Korean medicine came up and established guidance for mild and moderate patients. And according to the guidance given for mild and moderate patients, various herbal medicine prescriptions and disease pattern, differentiation was given. We took into consideration various materials of reference, and included in that was 청패 배독탕, which was recommended by the National Health Commission of the People's Republic of China. It is known as one of the most effective herbal medicines for treatment of COVID-19, and accordingly, we also gave it due consideration, and guidance for prescription dosage was established. And we conducted an observational study of patients who were prescribed 청패 배독탕 through telemedicine to observe the results and outcomes. Regarding our patient population, the COVID-19 patients who received treatment from February to April 2020, of which the number was over 2,000, we selected patients who were administered 청패 배독탕, and that left us with about 800 patients. And also regarding the inclusion criteria, patients who were confirmed as mild or moderate COVID-19 cases, and those who had received 3 or more prescriptions of 청패 배독탕, and those who had been continuously managed and successfully transversed into the convalescent recovery period were included. We follow up the patients to assess for sequelae, and 22 patients total were lost to follow-up. And so we were able to conduct follow-up after 6 months and analyze them in 27 patients. Regarding the characteristics of patients, the ratio of females was much higher. This may be attributed perhaps to the fact that the mass outbreak in Daegu occurred in the Shincheonji church. Regarding comorbidities, hypertension showed quite a high prevalence. Diabetes, cancer, and COPD showed lower prevalence out of comorbidities. And also regarding comorbidities and higher age, these were risk factors for transition of COVID-19 into development of a more serious stage. However, perhaps because our patients were enrolled in the early phases, their transition into more severe cases and stages was low. Also, regarding smoking, only 2 were current smokers, and so various risk factors for transients into severity were low. Regarding initial treatment, a high rate of 70% of patients had received none, and this indicates that mild patients were not provided with appropriate treatments, and they had to resort to taking cold medications instead. These were over-the-counter cold medications, and patients who were actually prescribed prescription medications such as paretics and antibiotics were very low. Almost none of these patients received radiologic examinations or blood tests. However, there were some who had gone actively to receive chest x-rays, and 22% had received chest x-rays and had been declared normal. So all of these patients can be considered to be mild patients. In this situation, for patients with suspected symptoms, they would receive examination and then wait for the results at home. And if they were declared positive and there was room to accommodate them at facilities, they would move there, or if there was not, they would stay home for self-isolation. After receiving the phone results that they had tested positive, still many patients stayed at home for self-isolation until they received confirmation of negative results and were released from the isolation. And analysis of these patients were stratified into these 2 different groups of home and facility isolation. The duration that the patients underwent self-isolation until receiving confirmed negative results and released from isolation was on average 30 days. Currently, the criteria for release from isolation regarding negative results have been eased, but at the time, patients were required to have received negative results 2 times on PCR tests for release from isolation. On average, 33 days were required for release from isolation. Regarding the duration of each stage in home and facility isolation, for home isolation patients, from self-isolation to symptom occurrence, the mean was 1.2 days, until confirmation on PCR test, 4.6 days, and from confirmation to change to negative results and release from isolation, 18.4 days. In those in facility isolation, from symptom occurrence to self-isolation, on average took 1.5 days, and after self-isolation, a confirmation of positive results on PCR, 6.7 days, and confirmation until facility isolation, 4.7 days, and from facility isolation to change to negative results on PCR, 28.9 days. This can be shown as a graph as follows. Regarding the duration, if the study design had been planned prospectively, we would have been able to compare whether the duration changed according to a herbal medicine prescription. However, the current circumstances as an observational study did not allow for this. Regarding analysis of patients prescribed 청패 배독당, from confirmation of positive results to their calling the Korean Medicine Telecenter took an average of 19.4 days, during which treatment was not provided. Also, as mentioned earlier by a different speaker, it took time for them to acquire this information of Korean Medicine Telecenter services through their acquaintances. And so, through better publicization, we hope that we can hope to accelerate the duration for these patients until they receive negative results to be much faster. Also, regarding the duration of herbal medicine prescription and administration, they took it an average of 15.8 days, after which they would transgress to the recovery period and be prescribed a different herbal medication. And so it can be seen that these patients were provided appropriate herbal medicine in the active phase. The main side effects of 청패 폐독탕 included palpitation, sleepiness disorders, and dizziness and diarrhea. And this was probably prescribed and attributed to the fact that 청패 폐독탕 includes 마황. And so in these cases, 마황 was removed, and afterwards we saw a resolvement of the side effects. With type 2 청패 폐독탕, in analysis of the breakdown of the components of 청패 폐독탕, as we all know, it consists of 마인 감석탕 and 사간 마왕탕, 소시오탕, and 오령산. However, it is not able to cover all of the symptoms related to COVID-19, and so there was need for use of concomitant medications. For concomitant medications, 소함융탕 and 곽향정리산, and the following prescriptions were used. After use of 청패 폐독탕, herbal medicine in the convalescent recovery period was used as follows for management. In the convalescent recovery period, prescriptions such as 경옥고, 자음 보패탕, 이끼 보패탕, 청패 경옥고, and 공진단 were used. And you can see that the main point in these prescriptions is that they were tonifying and nourishing yin. This table shows the main results after treatment compared with the early stages. In assessment of the severity of the main symptoms, the symptoms are listed as follows: sputum, cough, sore throat, rhinorrhea, chest discomfort, dry mouth, lack of appetite, and headache and dizziness. These were the most frequent symptoms. Regarding the severity, we collected the data based on a 4-point scale, and we later converted it into VAS scales. And for sputum and cough, out of a total of 100, sputum and cough each showed 13 and 15 points respectively. In change of symptoms after treatment with Korean medicine, most patients showed improvement, as can be seen in this table. For sputum, cough, sore throat, rhinorrhea, and chest discomfort, there was near resolution of the symptoms, and the results were statistically significant. And so this indicates indirectly the effectiveness of treatment. This figure shows the long-term symptoms that remain after 6 months, which were published in JAMA. And the main symptoms that were shown were fatigue, dyspnea, joint pain, chest pain, and cough. However, the JAMA data includes severe cases also, and so the patient population is different from the patients who were included in our study. Although there has not been publication of the results for long-term follow-ups in only mild cases, our patient population pertains to mild cases and so can be of reference. The long-term symptoms listed include fatigue and ocular symptoms. So patients complained of eyes becoming red and dry easily. Also, sore throat symptoms, they were included also in the acute phase symptoms and also in the long-term symptoms. Also, anosmia, which is dysfunctional sense of smell, was reported. Headache, dizziness, rhinitis, cough, dyspnea, dyspepsia, anorexia, myalgia, and sputum. Dyspnea symptoms were mild and they did not leave much sequelae, but still in some patients there was a little bit of a long-term dyspnea. Also sputum, which was high in the early symptoms, decreased greatly in follow-up. And in conclusion, in discussion, treatments for mild COVID-19 patients must be safe and have few side effects. As mentioned earlier, a lot of these mild patients were not able to receive appropriate treatment and had to resort to over-the-counter cold medications or prescriptions for anti-inflammatory agents. These treatments were not highly effective, and the treatments for mild COVID-19 patients should be safe, easy to administer, so easy intake, and be made available at low costs, as high costs would hinder availability and accessibility. In this regard, Korean medicine treatment could be considered as they are safe and are stable. And although the cost may differ by country, they are generally cost effective, and so it could be considered to be a candidate for treatment of mild COVID-19 patients. In this study, compared with other research, the rate of dyspnea was low as the patients that we saw were only mild patients. In cases of dyspnea, they would be classified as high-severity patients and be transferred or referred to hospital treatment, and so Korean medicine was not readily available to these patients. The cough pattern was also different. In severe patients who show dry coughs, the lung region involved is mainly the interstitial area. However, for our patients, the cough was generally accompanied by sputum. And this is because in the initial infection phase, it's mainly inflammatory and confined to the nasal throat and upper respiratory tract. In mild patients in the acute phase, the symptoms did not go deeper into the lung region. Also, while stamina was not very prominent in the acute phase, it appeared prominently in the chronic phase, and this may be due to overload of the immune system and lacking stamina. Secondary to attempts of the body to overcome COVID-19 taking toll on the patient's body. Limitations of this study include the fact that it cannot be representative of all mild COVID-19 patients, as the number of cases is small and is subject to selection bias. And although it was not designed as an RCT, it would still have been good to have conducted as a case control study for direct comparison of use of a treatment. However, this was not possible. And as we used telemedicine, we were unable to collect objective data such as blood test results, and we did not have any objective indicator outcomes. Also, due to shortage of time points of data collection, the study is not able to comprehensively reflect the change of symptoms during the duration of isolation. Still, collection of data towards accumulation of big data is meaningful especially for clinical practice, as this can be used pragmatically. So we should not differentiate between high-quality and low-quality data, but instead aim to collect all data to be put towards use in future clinical practice. Recommendations in other papers include use of detailed case reports, registry research, and observational studies that provide more detailed analysis. These types of studies are especially warranted and required in the current stage. Further studies need to be implemented in the future, including RCT studies. Especially regarding study design, we could devise study design where concurrent use of Korean medicine with conventional medicine is compared with a single use of conventional medicine. Although this is not an RCT, as seen in the image on the right, there are international registry researchers which are recruiting participant institutions currently, And so a collaboration with such institutions for accumulation and collection of global data would also be meaningful for future clinical practice as an evidence base. This concludes the end of my talk, and thank you for your attention.